I would like to welcome you all again to our Jabber Round meeting for dermatology. It is my honor to introduce to all of you our dermatologist speaker today. And now we shall start with interesting cases review with Dr. Shereen Aldaqdouqi. Please, Dr. Shereen is consultant dermatologist from Anjar Hospital. Please welcome Dr. Shereen.
We will start with our first case condition. This is an 18 years old female presented to our dermatologist containing of a slowly growing growth over the dorsum of her left foot or more than 1.5 years. Medical and family histories were irrelevant. There was a history of travel to KSA and frequent visits to their arm equally. An examination, a reddish to vivacious brown, translucent, soft, tumor-like, osteoproliferative growth of 2.5 by 4 centimeter in diameter. The surface shows post-light areas nodules with superficial ulcers oozing under crustaceans. The surface of the lesion is non-scaled, smooth, and tender. The lesion is not uniform in its appearance, as it shows cross expansions in some areas and healing of the others. Ulcers are reddish brown, superficial, round, irregular, with little thin pus. The edges of the ulcers are irregular, soft, and red in color. Skin elsewhere of the body, scalp, nails, and oral cavity were free on examination. Here is the lesion. It is a tumor-like lesion, measures 2.5 by 4 centimeter in diameter, reddish to violaceous brown, shows most of the lesion formed of 2 deeply seated nodules. The ulcers of the nodules show some ulcers as in the erosions or crustaceans. The tumor is not uniform in its appearance. It shows area of cross expansions and area of regression, especially at the periphery of the lesion. There is a newly developing nodule in the anterior aspect of the tumor. Clinical differential diagnoses were bacterial granuloma, such as TB or leprosy, fungal granuloma, such as urticosis or chromoplastonecosis or actinocytoma, leishmaniasis, sarcoidosis, foreign body granuloma, or a neoplasm such as Kaposi sarcoma. Investigation done. Skin biopsy showing nodular granulomatous dermatitis. The granuloma is formed of epithelioid cells, giant cells, and surrounded by lymphocytes. The overlying epidermis show is known as hyperplasia. Tissue culture showing no pathogen isolates, and there was a positive result for tuberculin test of the fine protein derivative, and T-spot test for TB was reactive. X-ray of the left foot and chest were free. So our diagnosis was hypertrophic lupus vulgaris or tumor type or nodular type. Histopathological examination of the 4-megaly incisional biopsy specimen showed pseudoepitheliomatous hyperplasia of the epidermis, overlying non-caseated tubercular granulomas, consisting of epithelioid histiocytes, lymphocytes, and Langerhans giant cells in the papillary dermis. Patient was referred to TB hospital where she was prescribed anti-tuberculosis medication, emactazide 350 mg, 2 capsules daily, a course of 6 months. 3 months after initiation of anti-tuberculosis medication, there was complete resolution of the less elevated areas of the lesion, a partial resolution of its 2 prominent nodules. 6 months after termination of the anti-tuberculosis medication, there was complete resolution of the whole lesion, the atrophic contractile hypo and hyperpigmented scar. Here is the lesion 3 months after initiation of the anti-tuberculosis medication showing partial regression, and after termination of the anti-tuberculosis medication, a course of 6 months, there is complete resolution of the lesion, healing with at contractile atrophic hyper and hyperpigmented nodules, and this is the nodule, the advancing nodule also showing the atrophic scar, highly pigmented atrophic scar. The history of cutaneous tuberculosis dates back to 1826, when it was first reported by Manning. He reported a lesion on his hand that was caused by entry of the causative organism into his skin. However, the causative organism was not known until 1882, when Robert Koch was first discovered mycobacterium tuberculosis. Later, it was isolated from cutaneous lesions of an affected person. Lupus vulgaris is the most common form of cutaneous tuberculosis caused by contagious spread from underlying tuberculous focus, such as lymph node borne from joints, lymphatic spread, or lymphatic spread, or hematogenous spread. It can also develop as the site of direct reticulation of kidney vessel lies through abrasion on the skin. It can be acquired from a human source or animal source also. Here we present a new case of lupus vulgaris. It is a hypertrophic or tumor-like or nodular on the dorsum of the foot. As the predilection site of lupus vulgaris is the face, which is accounting for more than 50% of cases, followed by the leg, buttocks, and extremities, most probably by direct inflammation through weakening bare feet in the farm. Complications of lupus vulgaris are secondary infections, most common septic infections such as typhus and dermatitis, lymphangitis. Lupus vulgaris may be complicated by lymphangitis or lymphadenitis, resulting in destruction of lymphatic vessel or lymphadeneules and lymphatic obstruction. Other forms of tuberculosis. Patients with lupus vulgaris can have tuberculosis in other organs. It is estimated to be about 25% of patients may have active pulmonary tuberculosis, and 30% of patients with lupus vulgaris may have active bony tuberculosis. Skin cancer, squamous cell carcinoma, can be complicated in long-term untreated lupus lesions, and the incidence rate is about 1 to 2%. However, PCC also recorded, but less common. Other complication is the destruction or mutilation of underlying structures, especially cartilage of the face, the bone and joints, and it can cause joint mutilation. Thank you for your attention.